Hi, I'm Matt Nielsen.
And I'm Matt Malowski, speaking to you today from the UNC Lineberger Comprehensive Cancer Center in Chapel Hill, North Carolina.
We are grateful to BJU International for selecting our work to be featured as Article of the Week for the July 2014 issue of the journal and giving us the opportunity to be here. We would like to briefly contextualize this study in the prior body of literature and also what we believe to be some of the important questions it highlights but does not answer that could be opportunities for further research.
While cystectomy has been associated with an overall survival benefit compared to less aggressive management approaches, particularly in Gore's elegant analysis in the JNCI, the magnitude of the procedure also carries a potentially high risk of short-term morbidity and mortality.
As seen with other complex surgical procedures, the risk of short-term mortality following cystectomy has been inversely associated with a given hospital surgical volume. Put another way, hospitals with a higher volume of procedures have been consistently shown to have lower mortality rates, both in-hospital and in the historical standard window of 30 days postoperative. Birkmeyer initially described this volume outcome phenomenon in a seminal New England Journal paper in 2002, and the finding in cystectomy has been replicated by Hollenbeck and others in our field in the ensuing years.
In parallel, there has recently been an increasing recognition that mortality rates after complex procedures are substantial in the first 90 days, with rates of 6.7 to 8.2% observed in several studies of cystectomy. Recognizing the well-established association between hospital volume and mortality in the first 30 days after surgery, there is a question whether, and if so, how the volume outcome effect is associated with the endpoint of 90-day mortality. In our sample of over 35,000 patients who underwent cystectomy for bladder cancer at one of over 1,000 hospitals, we observed unadjusted cumulative 90-day mortality of 5.7% among high-volume hospitals compared to 8% among low-volume hospitals. These data add to the body of literature underscoring the relatively high and variable early-term mortality risks after cystectomy, particularly among those performed at lower volume centers as well as among subgroups of patients. To that point, among patients 80 years and older, the cumulative 90-day mortality in these data was greater than 15%, supporting the value of work by Morgan and others to develop risk stratification tools as aids for shared decision-making.
However, recognizing the inherent potential bias of 90-day mortality rates from shorter-term deaths, we sought to examine the independent effect of hospital volume on intermediate-term mortality beyond the 30-day window by separately examining 90-day mortality predicated or conditional on survival beyond 30 days. As shown in the top of Table 2 in the paper, we found 30-day mortality rates of 3.2%, 2.5%, and 1.9% among low, intermediate, and high-volume hospitals, respectively. On top of these numbers, we observed conditional 90-day mortality rates of 4.9%, 5.1%, and 3.8%, respectively. To emphasize this point, we note that even among the high-volume hospitals, nearly 4% of patients alive at 30 days died within the next 60 days. The adjusted odds ratios for 30 and conditional 90-day mortality are presented in Table 3. How can we explain these observations? The concept of failure to rescue, i.e. case fatality among patients with complications, has recently come to light in a nice body of work by Gaffari as a stronger mediator of differences between hospitals with low and high 30-day mortality as compared to differences in the absolute incidence of complications, which are, in general, comparatively small. A recent study by Trin supports the relevance of this mediator to the volume outcome effect in cystectomy as related to shorter-term mortality.
This concept may be relevant to our observation of substantial mortality in the period between 30 and 90 days, as delayed complications are common after cystectomy. Donat found that 54% of patients at a very high volume center experienced grade 2 to 5 complications, 57% of which occurred between discharge and 90 days. Despite the many strengths of the NCDB data, we were not able to elucidate causes of death or complications. Future research and other data sets could explore these findings further.
In conclusion, hospital volume is inversely associated with 90-day mortality after cystectomy. However, this observation is largely driven by variation in shorter-term outcomes. The results of this study point to the need for additional research to better characterize potentially actionable root causes of mortality in the window from 30 to 90 days postoperatively, where mortality rates are relatively high across hospital volume strata.
We would like to acknowledge our collaborators, in particular Kathy Mallin and David Winchester from the National Cancer Database Program, as well as Mark Weaver from Biostatistics here in Chapel Hill.
Thanks very much.